Dr. V. John, you want to say hi as well?
There we go. Hi, everybody. This is Dr. Horn.
You have done, I think, John?
There we go.
Oh, perfect. Hi guys, can you hear me, John?
Yes, I can hear you. Can you hear me okay?
Yeah, perfect.
Okay, great. And if anyone has any questions, please feel free to type in the chat box or ask us after the presentation. We'd like to cover, kind of the information that people are asking us and some of the questions that we're getting about the clinically relevant, questions about what to do when you get patients, how to treat them, what kind of isolation they should be in. And this is all kind of rapidly evolving. So day to day, some of the recommendations do change. Even these case numbers that we have on the screen right now have changed just from yesterday to today. So a lot of this is rapidly evolving, and a lot of it you have to take in the clinical context in your area. So what's happening at your hospital, in your location, and kind of try to kind of take the information that is coming out kind of, as it changes, as we don't have great studies. We are getting a lot of studies, but none of it is, great. That the IDSA recommendations, as far as the guidelines go, they're kind of what we have at the time.
Yeah, and then as things are changing, we'll try to keep up with them and kind of update you guys. And we'll try to go over our slides really quickly so we'll have more time for you guys to ask questions and answers. Again, John and I are just learning as well. A lot of things we don't know the answers to either, but we'll share what we're doing.
Right.
So I'll start off.
Oh, sure.
I'll start off with current cases as of May 4th. We had about 1.1 million cases and about 67,000 deaths, but that number has gone up, like Dr. Horn was saying.
Right, and these total deaths, 67,000, I believe about 20,000 of these are out of New York. So New York is very hard hit here.
And if you look at this graph, it kind of shows us exactly what states are having more cases and deaths compared to other states. Again, this is a time shot of one time, but things are changing as we're opening up more states and loosening up some of the restrictions. We are probably going to see different patterns, but for now, this is the pattern we have.
And here are the symptoms, and really I think what they're seeing is kind of a wide array of symptoms. And so a lot of patients are presenting kind of in different ways. One of the things that makes this different than some other types of infections is that this can start very slowly. It can come on slowly. I think the average day to hospitalization was around day 9 or so. So the patients, and that's one of the reasons it can spread so well, is that the patients say, well, I'm not that sick, or I don't feel that bad. And they can spread before they have symptoms. And then even when they get symptoms, it kind of builds up slowly. So people don't, they're not sure if they have it, and they don't want to stay home if they're not really sure, or they're short at work. So people still go to work even with some of the mild symptoms, and then it comes on slowly and gets worse and worse over time. So it's not some other illnesses like classic pneumonia, for instance, will hit someone all of a sudden. So they're sitting at home and all of a sudden they have a fever and chills and feel terrible, whereas this comes on kind of gradually.
Yeah, and then CDC recently updated these about a couple of days ago as well. Before they had the main symptoms, they had the cough, shortness of breath, and fevers, and but then now they have added the symptoms below as well. So now they're saying cough, shortness of breath, or difficulty breathing with at least 2 of the below symptoms. So some patients, I'm going to talk a little bit about later about loss of smell, loss of taste. Some are having muscle aches. Some are having less than 10% have some diarrhea. So I think what this tells us is it's really important that now that we protect each other, and that's how I talk to my colleagues, my patients. If you have any of these symptoms, if you're not sick enough, And if you just have to stay at home, so we don't want to expose others.
Right.
If you're sick enough, then come to the healthcare facility.
Oh, and even it says fever, but I think they're calling a fever here above 99 or 99 and above. So even if it's just a temperature of 100, 100.2, still you should still take it seriously and really stay home and kind of think about, would you want to go to work knowing your coworker had what you have right now, right?
Yeah.
So if you are just having a mild headache, mild fever, still consider staying home and try not to expose people.
I listen to our state Monday, Wednesday, Friday calls, and some of the stats are like over 28% of our certain long-term care facilities, for example, have had infections, and a lot of time healthcare workers going in without knowing. So it's really important that any healthcare facility, we need to have good checking symptoms and taking temperatures, and then also all of us being very vigilant about like what kind of symptoms do I have today, and if I'm not going exposing others. And this slide kind of just tells us the incubation period, and up to 14 days, but usually you start with symptoms about day 4 or day 5. So a lot of times the questions I get asked is like, I was just exposed to a patient I didn't know, like yesterday. Am I contagious the day after? Usually if you look at this, you're probably not infected immediately in a day. Usually you're going to start having symptoms around day 4 or day 5.
Right, and we try to focus on, I believe you're most infectious at the time you're having symptoms. So it's one of these things where if you try and isolate yourself, and when to isolate yourself, the most important time would be if you're having symptoms, if you're having, uh, anything, even if it's very mild. Those are the important times to really isolate yourself. How long to kind of stay away from people and self-isolate is kind of in question. There are some studies showing that it can stay, the test can remain positive for a long time, and they're really not sure about how long to isolate. Is that still relevant if the patient's no longer having symptoms and these things? A lot of this will get worked out, but as far as self-isolation, I think we'll actually talk about that more
Yeah.
as far as symptoms.
It's coming up. So for clinical presentation, um, um, this is from CDC. They looked at multiple different studies and kind of gave us a range of the symptoms. So fever is one of the most common signs, cough. A lot of people feel fatigued. And then there's some anorexia, shortness of breath, and those that severely have the infection, some sputum production, and myalgia. So that kind of, they looked at multiple studies and kind of pooled the incidents together. And I thought to include this study because, it kind of tells us about like other symptoms that patients are having: headaches, confusion, rhinorrhea, runny nose, sore throat, hemoptysis, vomiting, diarrhea, about less than 10% of time. So a lot of times we get asked questions, this patient has diarrhea, do they have COVID? For me, what I always think of it as like, do they have cough, shortness of breath? Those are my main things, or fever. And then if they have those, plus these are my additional symptoms. But if somebody just comes in with diarrhea, they don't have anything else, less likely they have COVID. But still important to keep in mind about exposure and things.
Right, and I think this is a great slide because this shows that the atypical presentations, it's really hard for someone to say, since they have gastrointestinal symptoms, they don't have it. So it's hard to exclude patients based on their symptoms because there are so many different ways that they're presenting. So I think that's a great slide.
And this is that study, self-reported smell and taste dysfunction. So they looked at some patients. The study was done in, next slide, please. and kind of looked into how many people had these smell and taste issues. So about 33% have reported at least one taste or olfactory disorder, and 11 both taste and smell. So this was about out of 20 patients out of 59 that were interviewed that were hospitalized. So that's kind of interesting because, a lot of times, like I have had some patients where they just present with like, I can't smell all of a sudden, or I can't taste. And one patient actually was eating dinner, and middle of eating dinner, this patient lost smell and taste. So they call the next day he called me. He's like, "What do I do?" And then we got them tested. So that was interesting, losing smell and taste.
And here we have two slides. One is going to be for patients with COVID-19, and then the next slide is going to be who do not have COVID-19 symptoms but tested positive. So here, the two approaches, there's a symptom-based strategy, and the second one is a test-based strategy. And the test-based strategy is also, a lot of these things are dependent on if you have the test available, how easy is it for you to get the test and test your patients. And so here's the symptom-based strategy. It says persons with COVID-19 who have symptoms and were directed to care for themselves at home may discontinue isolation under the following conditions. At least 3 days, so 72 hours have passed since recovery. So that's after they are no longer having symptoms. And that's defined as resolution of fever without the use of fever-reducing medications and improvement in respiratory symptoms. And at least 10 days have passed since symptoms first appeared. So 10 days since symptoms first appeared and 72 hours after they've essentially made a recovery.
I do want to chime in on this because before CDC had this, I would say about 3 to 4 days ago, less than a week ago, for a long time, they said 7 days of recovery, 7 days of onset of symptoms with 72 hours of no fever. And then recently, things are coming out that people are maybe more infectious up to 10 days or so. So now they went ahead and changed it to 10 plus 3 days of no fever.
And then the test-based strategy, and this is, they say, however, a test-based strategy is contingent on the availability of ample testing supplies. So if your facility is able to do these, multiple tests, so persons who have COVID-19 who have symptoms and were directed to care for themselves at home may discontinue isolation under the following condition: resolution of fever without the use of fever-reducing medications and improvement in respiratory symptoms, and a negative result of a FDA emergency use authorized COVID-19 molecular assay for detection of SARS, so detection of COVID from at least 2 consecutive respiratory specimens.
And 24 hours apart.
And 24 hours apart. So, and I believe that's what they were doing in Italy. I think in Italy they were making sure they had 2 negative tests before they would allow them to leave the hospital. I don't, if patients are doing well, I don't know that I would hold them up from going home, especially if it's in the community.
Yeah.
Right?
So my strategy has been, if you're going home and you're staying home, then you could go home. Doesn't matter if you're day 5 of illness, go home and keep yourself isolated until you get better. But, where we are, I'm sure everybody has come into this issue, is when we go to nursing homes, definitely they're asking at least test 2 tests negative from day 14. So what we're learning that's kind of been interesting is a lot of the elderly patients, even at day 14, tests are remaining positive. And some patients, in my experience, are positive at 5 weeks, 6 weeks later. So, there's some CDC actually had some of this information saying that, is a viral still alive, or are we just picking up dead viral RNA? We don't know, but there was some emphasis on, like, if you're immunocompromised, compromised, then you might be shedding live viruses, just like other viruses, you have more viral replicating. But I am not sure what to make of when patients test up positive at 5 weeks and they have no symptoms. I'm struggling with that too. But I'm assuming they're not infectious at that time. But wearing masks and things, we help each other to continue to, protect each other, universal masking.
And then here we have, for persons who have not had COVID-19 symptoms but tested positive and are under isolation. So time-based strategy, the persons with laboratory confirmed COVID who have not had any symptoms and were directed to care for themselves at home may discontinue isolation under the following conditions. At least 10 days have passed since the date of their first positive, assuming they have not subsequently developed symptoms since their positive test. So if they develop symptoms, then the symptom-based or test-based strategy should be used. So that would be the other slide. Note that because symptoms cannot be used to gauge whether these individuals are in their course, where they are in the course of their illness, it is possible that the duration of viral shedding could be longer or shorter than 10 days after the first positive test. So, it's difficult to know what to do with these patients that, may not have symptoms but are testing positive. And then the test-based strategy, persons with laboratory confirmed COVID who have not had any symptoms and were directed to care for themselves at home may continue isolation under the following conditions. Negative result of one of these molecular assays for detection of COVID from at least 2 consecutive respiratory specimens collected greater than or equal to 24 hours apart. So it's similar to the previous slide for the test-based strategy.
So here is pool of information they pulled together. It's about on 44,000 patients, and this study was from China to look at exactly what are our majority of patients mild to moderate, 80 up to 81%. Severe symptoms, were in some 14%, and then critically ill patients were in the about 5%. In the study, all death occurred among patients with critical illness, and the overall case fatality was 2.3%. And case fatality rate among patients with critical disease was 49%. So a lot of the studies, even out of New York, that is coming out is that, when patients are intubated and they're severely ill, their mortality is up to 50% or more. So, our goal is to not to get to that point, but when patients do get intubated, their outcomes are 50-50 kind of poor. John, do you want to add anything?
Oh, no, I think that's exactly right. The patients, and this is with many types of infections, that some get it really bad and some don't, and it's hard to tell which patient's which. I think as far as the severe and the critically ill patients, right, the things that they're finding and that they have in common, I think elderly, obesity, comorbidities, chronic lung disease, these type things are,
And, what we're seeing in our hospitals, definitely the comorbidities is a big, diabetes, heart disease, lung disease. And it's also really, we're seeing a lot of young people too, who are, I think one of the big factors is their BMI is really elevated. So yeah, wide array of patients, and comorbidities play a big role in them.
Yes, I think you're right. Heart disease, diabetes, these things are, and then clinical progression among patients who develop severe disease. The mean time to dyspnea range from 5 to 8 days. So this is what I was mentioning. It comes on kind of slowly, and the median time to acute respiratory disease, so ARDS, range from 8 to 12 days. So it's kind of, it can come on slowly and then progressively get worse, and the pulmonary symptoms progressively can get worse, even at day 8 to 12 when they start to really have problems. Median time to ICU admission range from 10 to 12 days. So I think days to hospitalization was around day 9 or so was the was around the time, and then they continue to progress, and day 10 and 12 continue to worsen.
And then what we're noticing is when the patients are in the ICU, they're remaining in the ventilator for minimum 2 weeks, some 3 weeks. So but it's interesting because, as I'm reading, but now as I'm seeing patients, patients initially are really critically ill on the ventilator but then they're slowly getting better, but they still remain on the ventilator. So for me, initially seeing all these patients really critically ill, but they're still ill, but now their oxygen requirement is at 40% FiO2 versus 85%. So a lot of the patients just need a lot of time and just patience and ventilator support. Some of the things that I've noticed the ICU docs using is when the patient does have ARDS, they're using steroids for that. So I've seen that being done now. And also they're trying to minimize the amount of fluid giving to these patients to cause pulmonary edema. And then I'm seeing in our ICUs and on our floors, we're doing proning. So proning is really important to be able to oxygenate your lungs better. So even before a patient gets to the ICU and gets intubated, we're encouraging patients to be proned, stay on their belly as much as they can on the floor. So let's say they're on the floor and they have some shortness of breath. We're asking them during the day, can they stay on their abdomen for like an hour at a time for 5 times during the day? Or even if they're on oxygen, if they could tolerate being on their abdomen. And that recommendation is coming out from lots of different places, and we have had some success with that as well. So we're some of our patients, when we do this, they do better and they don't need intubation. So proning, limiting the number of fluids, those are going to be very key as well.
Yes, and one of the questions that we get when patients arrive in the ER, and sometimes we'll get called and they'll say, this patient, I think they have it, they don't look too bad, should I keep them or send them home? And these are one of the questions that we get where, it's kind of one of these things where we can't really tell, we can look at their comorbidities and decide, make some decisions from that, but it's hard to tell which ones will progress and get worse and which ones won't. So it's hard to give an answer, especially if we're getting a telephone call asking, should we admit or should we send them home? And they would say, normally with this type of patient, I would send them home. My feeling is it's kind of difficult to admit someone if you don't think that they need a hospital bed, especially if hospital beds are a scarce resource. And I understand it's difficult to tell them to go home and come back if they get worse. That's difficult to do. But it's one of these things where, like most of this, it's really the clinical judgment and talking with the family and discussing, from your point of view, from a medical point of view, to the family members, and discussing it. That most patients do well, but some patients will get worse. But it's hard to kind of recommend filling up the hospital with patients that look okay, that you'd otherwise send home. Would you agree with that?
I do. I've been telling, if patients are looking okay, I think a better place for them is home, and sending them home. And then we tell the patients to call or come in when they need.
Yes, especially for respiratory symptoms. Yep.
Yeah. Agree. Okay. Next slide.
All right. So next one, progression.
I just like this picture.
Oh, great. Yes.
Go ahead, John.
Oh, yeah. So here's, sometimes it's looking at CT scans from patients. I like these pictures as well, kind of these cartoons that show, what in general, what they're seeing here. So this is figure 1. This is A is the normal lungs. So the top and the bottom on the left side are the cartoon illustration of the normal lungs, and then you have on the right, B is the early stage unilateral. So this is on the right side, multifocal, peripherally based ground glass opacities. And so you can see the ground glass opacities here and here. And so it could be, it could be just on one side, it could be unilateral, it could be bilateral. But the ground glass opacities are really what can key you into, does this patient have COVID? whether they're showing really the typical symptoms or atypical symptoms. You know, the CTs have been shown to be very good, and some people, some of the radiology groups say they're better than the actual test. But and here again, this is progression of the lungs. So here it's showing progression. So on the left side, you have further evolution of the peripheral-based ground glass opacities. So you can see the ground glass opacities on both sides. And now they're bilateral and multifocal. So this is the kind of thing you'd see with viral pneumonia. These kind of it's kind of patchy. It's not like a typical infiltrate that you'd see for a bacterial pneumonia, which would be a consolidation in one area of the lung. This is kind of all over with ground glass opacities, usually in the lower lungs.
And we got a couple of questions I wanted to quickly answer. How long do we shed the virus? Honestly, it's kind of hard to say, but what we're learning is that immunosuppressed patients shed the live virus longer. But even in like immunocompetent patients, if you do the PCR testing, we're finding positive tests, but nobody is sure if it's dead virus or live virus. So immunocompromised patients, longer viral shedding. Another question is, how long can a healthcare worker with confirmed COVID who has been asymptomatic for 21 days still test positive, and when can they return to work? So what I would take the CDC guidance if symptoms-based strategy instead of test-based, because if you're immunocompetent, I would say at day 10 with no fever for 72 hours and no shortness of breath, no cough, no symptoms at all, then they could come back to work, but with masking at all times. And universal masking in healthcare facilities are now recommended by CDC, Joint Commission. So as long as we're doing that, we should be good. This study kind of found that what are the laboratory findings that are really concerning? So a lot of our patients were seeing lymphopenia, so lymphocyte less than like 500, 800 to 500 range, which is not very good for patients. Then we also ALT, LDH, high CRP, high ferritin. The LDH, ferritin, CRP, these are really high in patients who are having cytokine storm, lots of inflammation in the body. And some studies are also showing D-dimer plus low lymphocytes, actually patients that associates with patients having bad outcomes, higher mortality. And then should we be testing for procalcitonin? So when I'm taking care of these patients, it's really tricky because when they have all these bilateral infiltrates, you're trying to figure out, is it COVID? Is it bacterial infection? So some of the tools that's been really helpful for me is getting a procalcitonin. So if it's elevated, then I'm like, okay, there might be a bacterial component on top. Let me trend. So if they're procal, they're intubated, not doing well, their procal is 10. So I treat them for bacterial and then I trend it. Another also useful tool is if you don't have procal in your facility, using CBC with manual differential. So then you keep an eye on the neutrophils and the bands. So let's say somebody is, bands, if they have 10% bands, that's abnormal. Anything more than 5% is abnormal. So then you're like, okay, maybe there's a component of bacterial infection. Another things that are really helpful is doing the things that we usually do for other viral infection, and then we worry about, could you have a bacterial infection? Blood cultures, sputum cultures, those are really helpful. So in my patients who have COVID and they're not doing well, I get sputum, I get blood, and I've found a lot of co-infections. Some of my patients have pseudomonal pneumonia on top because they're on the ventilator for like weeks. So now you're getting hospital-acquired pneumonia pathogens. Some of my patients have had MSSA and MRSA infection, Haemophilus influenza. So it's still really important to look for those bacterial pathogens on top of the viral, and then treat them for like 5 to 7 days, like we usually would.
Right, I think that's great. I think originally they were saying that superinfection with bacterial, like a bacterial pneumonia, would be extremely rare, but I think it's actually being seen a lot more than they were first saying. I think originally I think it was less than 2% or so, and now I don't know if it's 10% or where it's at now. I think, but originally it was thought to be extremely low. Um, would you agree with that, or would you say it's
Yeah,
more?
I think originally, but now I feel like we're seeing more superimposed bacterial
Um,
infection. But what one of my takeaway key information is that it's just like any other time you'll have a pneumonia, and
right.
it's just important to get those labs and sputum and blood culture, and just treat it for like we would if it's a community acquired pneumonia. Treat it for 5 to 7 days. If you've got a hospital acquired pneumonia, for 7 days, and not treat it for longer than that. Just have a timeline and kind of
Yes,
follow that.
I think that's great. I think if you have a positive COVID test and you're not suspecting a bacterial infection, then that would actually give you a reason to stop the antibiotics uh, but just like you would for any viral infection. So a lot of this is clinically, what is your clinical suspicion? Are you suspecting it or not? Okay, I think that's great. Oh, and here, this is the next slide, antimicrobials. So I think you did a great job discussing whether or not to start antibiotics or stop antibiotics if it's purely COVID. So as far as hydroxychloroquine and
Yeah.
azithromycin at this point, what are your thoughts on that?
So, um, as the studies are coming out, it's more and more shows it's more harmful than benefit. So, especially when we used to use hydroxychloroquine as a throw together, a lot of QTC prolongation, a lot of arrhythmia issues. And recently there was a couple of studies that, the last one was from the VA study where they looked at a large population of veterans, and they monitored, and it didn't really show any benefit, maybe more harm. So we have gone away, I'm not giving any hydroxychloroquine.
Hmm.
I am using azithro if I'm worried about community acquired pneumonia. So when I'm having a patient who is coming in with COVID-19 and I'm worried about pneumonia and they're coming from the community, then I'm using ceftriaxone and azithro in that manner, but I'm not using it hydroxychloroquine as a throw together. So question here is, our critical care physician used Actemra for cytokine storm. Do you have experience with this? Yes. So I'm going to get to that in a minute about IL-6. But definitely when you have patients with COVID-19, you can have community acquired pneumonia. You could have hospital acquired pneumonia. So remember to get MRSA nasal culture to see if they have MRSA. Get sputum culture, get blood culture, because I'm noticing we're forgetting to do these things in
Oh,
certain places I'm working. So it's really important we do those, because that really gives us more information as to. And then if it's we're still worried about community acquired pneumonia, treat for 5 days. Hospital acquired 5 to 7 days, and let's target those bugs. But then we need to get rid of them, and we don't prolong it.
that's a great recommendation to think of the common things being common. So CAP and HAP and not just focusing on COVID and shutting out everything else. I think that's great. So if a patient is on a medicine floor, so they're not in the ICU, not intubated, and you're considering giving antibiotics, so would you still consider giving azithromycin plus ceftriaxone for like a community-acquired pneumonia, or would you, because we're getting calls and people are giving, they're starting out with kind of meropenem, daptomycin, or meropenem,
Yeah.
vancomycin, microbials, these things. Would you start with ceftriaxone and azithromycin, or would you, how would you do it?
So if let's say I have a patient who's coming from home, no other
Mhm.
exposure, and now I'm worried about COVID with a community acquired pneumonia like picture. It's hard for me to figure out. So I'm getting procalcitonin, CBC with manual differential. I'm getting sputum cultures. During that time, I will treat them like it's community acquired pneumonia. So I do ceftriaxone and azithro. Unless this patient is known to have like MRSA or Pseudomonas, I'm going to treat them like we would for any other patient, community acquired ceftriaxone, azithro, and see how they do and kind of continue to evaluate them. But if they're in the ICU and they've been, all our patients are here for weeks at a time. So, day 14 of intubation, and now they're not doing well, fevers, and then I get sputum culture, then I cover them for HAP, and then I'm like doing vancomycin, getting sputum, urine antigens, procal, those things to kind of help navigate through and kind of get those information, de-escalate, or do a 7-day course.
Okay. All right, great.
I really like this study because it showed when you have cytokine storm, what are the markers that are elevated. And some of the markers that are elevated out and decrease, so you get low neutrophils, white count is kind of okay, low lymphocytes, your PT, PTT all over the place, AST, ALT can go up, LDH can go up. So the next slide. So this was from Baylor University, where they use kind of this marker for cytokine storm. So I actually hope if maybe this will might help.
Mm-hmm.
So and then when to give Actemra. So Actemra is a IL-6 inhibitor, cytokine inhibitor. So what I have used Actemra on patients, but I'm trying to see who qualifies, and instead of giving it to everybody, seeing when do they have cytokine storm. So things that have been helpful is they must have lung infiltrates, they must be in the ICU, persistent fevers, but it can be masked sometimes, PF ratio less than 150, plus evidence of cytokine release. So if the CRP, 2 of these markers, so if CRP is greater than 20, if ferritin greater than 1500, LDH greater than 1500, D-dimer greater than 10, fibrinogen less than 200, if 2 of these markers with an ICU patient, then that kind of worries us for cytokine. So, obviously we don't have any clinical trials, but this is, we do available. So we have used it on some patients and have seen, trying to collect data right now. I would say more than 50% of the patient got better. Some patients, still deteriorated. So I don't know, we still need more data on this, but I have used it on patients when they're showing cytokine storm, especially the patients who have really high ferritin. I had a patient whose ferritin level was 37,000. And a CRP was extremely high. We gave Actemra, and the patient remained ventilated for over 3 weeks, and finally got extubated and went home. Again, I don't know if it's Actemra or the patient itself just got better. Just giving you guys some experience that I have had.
All right, and then remdesivir. This remdesivir, I think, has also gotten a lot of press with their studies. I think one of the questions we've been getting is, how can I get remdesivir? I think originally they had been giving it out as a compassionate use, and then they stopped it and said they would only be giving it out in cases of trials. And then what is where are we at now as far as remdesivir?
So you guys all heard that FDA has given emergency use and it's available. Unfortunately, we're trying to figure out how to get it too. So the last thing that I heard was FEMA is going to distribute it to each state depending on infection activity. So and then they're going to be able to distribute. But we only have last time I read there's about 140 to 200,000 doses for patients. So it depends, how are we going to get it where we are? So more to come on that. I don't know than that either. I've been talking to our State Department and things too, but waiting for more information. And, sorry, go ahead.
Oh, I was just going to say, this is how they were giving it, and this is looking at the treatment mortality. So 5 days versus 10 day, no difference. I think that, what are your thoughts about how well it works? I think some of it was kind of leaked out to the press kind of early.
Yeah, so only thing that I found very positive was the rate to recovery, 11 versus 15 days. So that does make a big difference in our patients. If you have 3 to 4 days decrease in your illness, we give Tamiflu for few days, 1 day difference in your clinical process. So for me, I think that's a good idea. Having 3 to 4 day decrease in your illness.
Mhm.
It's also good to know 5 versus 10 days made no difference. So, if we do get the drug, we probably just give 5 days for our patients. I've been asked, like, who do you give the drug to? I'm still trying to figure that out, read more about it, but I probably give it to patients who are requiring oxygen, who are, bilateral consolidation, whose oxygen demands are going up. So somebody like that, or who's in the ICU. I probably would not give it to patients who are like doing fine, and that they come to the ER, get tested, go home, or they're in the clinic,
Right.
they're okay. They probably don't, they'll probably get better on their own. They're the 80%. I'll probably give it to the patients who are shortness of breath, getting worse in the ICU, those type of patients.
Yeah, I completely agree with you. That's my thought as well, is that I'd want to give it to patients that are very sick. I think this, my guess is this will evolve, because if it's faster time to recover, you'd think that if the earlier you give it, the better they would do, and then you can hopefully, not have them get intubated. Not, but these are all just speculation, because I completely agree with you. I would only give it to patients that are very sick. I think that's how it was tested.
Yeah. And 5 days should be good when we do have the drug.
Yep.
And then this is just, some talk about convalescent plasma. You can go to the next slide, John. There was a study published in JAMA. 5 patients got convalescent plasma. They were critically ill. They all got better.
Mhm.
So we registered with Mayo Clinic. Mayo Clinic currently has a trial for convalescent plasma trial. So, your providers can register and then get an IND and be able to use the plasma on your patients if they're not doing well. So again, who do we give it to? A patient who's getting worse, whose clinical status is going in the wrong direction. You could use convalescent plasma if it's available in your area. In our area, LifeServe and Red Cross, they're collecting right now, so that is an option. We have given it to patients. Patients have gotten better. Again, it's all like we don't have studies, so we're trying to collect data. It's really hard for me to say that worked and this doesn't, but we have given it to patients, and we're part of the Mayo Clinic study, so we'll see more to follow.
Right, and these kind of case reports, it's hard to recommend it exactly, because it's only 5 patients, and some of them, I think it says the age range, some of them were about 36 years old, so it's hard to recommend it, in patients that may not have done too poorly anyway. But I think this is exciting. I think this is something that definitely could be, we could be hearing more about, and definitely could be working.
So if your facility is interested, you can register in the Mayo Clinic protocol, your providers, and if your blood bank can get convalescent plasma, then you can use it. We have done it, but I don't have data to tell you guys, patients have gotten better, but I don't know if it's because of that, so more to come. But Nebraska, we do have this available.
Right.
People are donating.
Yeah. So these are getting antibodies from patients that have gotten better, and so it's essentially, I think the gist of it is this bottom part here, that it raises the possibility that convalescent plasma transfusion may be helpful in the future, but we need more studies to show that. And here's a bit about anticoagulation. I think these patients with COVID have, are at increased risk for their higher coagulability, increased risk for PEs. A lot of the patients that we've been discussing, that we've been getting calls on, have either DVT or PEs. I think the D dimers have been extremely high in these patients. So here, this was essentially looking at, should they be anticoagulating? And I think most of the algorithms, the treatment algorithms, do have some anticoagulation pathways on there. Anticoagulant therapy, mainly with low molecular weight heparin, appears to be associated with better prognosis in severe patients with meeting the criteria with markedly elevated D dimer. So I think these pathways, the algorithms that most hospitals, I think, are sharing, is that if they meet certain criteria, that giving them anticoagulation does improve mortality.
Next slide, and I will kind of show that to you guys. This was a study that was published, but the next slide I kind of took these slides from our Nebraska State Health Department calls. So basically, if anybody has COVID-19 infection, if there's no contraindication to anticoagulation, they should be on prophylaxis. So either low molecular weight heparin or heparin sub-Q for prophylaxis if their D-dimer is low. But if the D-dimer level is elevated, a lot of places are doing an intermediate anticoagulation dose. I'm not an anticoagulation expert. I'm just telling you guys this. And then if there's high level of D-dimer, then they're doing full dose anticoagulation. So and then some patients are getting discharged on anticoagulation up to 2 weeks after they leave the hospital. So I think it's still more information to come, but Mount Sinai has a protocol, Harvard has a protocol, a lot of places you could look it up online, but a lot of places are giving anybody with COVID-19 infection prophylaxis with low molecular weight heparin or just heparin sub-Q, intermediate dosing for the D-dimers in the middle range, and if it's really elevated, because some patients I'm seeing D-dimer that like if a normal is 0.5, it's like 35 on the top end. So those type of patients, our ICU docs are fully anticoagulating them.
Yes, and when COVID first started coming out, a lot of the media would talk about patients that seemed like they were getting better, and then all of a sudden they would drop dead, and that really sounded like PE to me. And and this kind of this correlation came out.
So it's good, really important to be able to kind of keep an eye on the D-dimer and make sure patients are minimum on a prophylactic dose. So that's our last slide. So questions you guys have for us? You could type it in the chat box or unmute and talk to us. So I would say, sorry, go ahead, John.
Oh, I was just going to say a lot of this is, when the IDSA came out with their guidelines, a lot of it, they didn't recommend any treatments outside the context of a clinical study.
Yeah, I was kind of upset about that because they really didn't provide any help for anybody.
Yes, that's right. That's how I feel. Is they said you could do this in the context of a study, and that's really and a lot of it they essentially just had in parentheses more studies are needed, and it wasn't really as helpful as people were expecting when it first came out.
Yeah, so but I think some of the key takeaways are if you have a COVID patient, they can have CAP or VAP, but getting cultures and targeting that for that duration and not extending it because we don't want to give them C. diff and resistance. Another takeaway is making sure we keep an eye on the anticoagulation component. And then hydroxychloroquine is falling out of favor. IL-6, Jeff, has their you have the standard dose of Actemra, you have used 400 milligrams. So for Actemra, you could use a couple of doses. You could do 400 and a follow-up dose the next day. Your max dose is 8 milligrams per kilogram. So I have just done 8 milligram per kilogram times one-time dosing and not go over 800 milligrams. But you can do 400, and then if they're not doing well, 400 the next day. I have just given my patients the highest dose times once and then left it as that. Thank you.
Okay, great. So, let's see.
From what are you seeing? What % of patients that die have comorbidities? From what I'm seeing, they all have comorbidities, unfortunately. Yeah, they're older and they all have comorbidities most of the time. Majority of the time. Yeah.
I think, I'm not sure of the most recent email from the health department. I think we've had about 70 patients in Nebraska die. Is that around the right number? I think it's somewhere around there. I'd have to see, every, the health department sends out emails giving updates. It's, I'm not sure what.
Yeah, and then they said more questions at the top. Is how long, I can readdress that, how long do the virus shed? I think when you're symptomatic, you shed virus, but some people are turning positive even at 5 weeks. We probably not live viral at that time. If you're immunocompromised, you're shedding virus for a longer period. Healthcare workers, they can return to work. If you're using symptoms-based strategy, no symptoms after 10 days minimum, with no fever for 72 hours without any fever-reducing medicine. Any other questions you guys have?
All right, great. Well, thank you everyone for joining our webinar. If you have any questions, please email us, or any topics you'd like to cover in the future.
Yeah.
Thank you very much.
Please do, and then we'll continue to keep you guys updated. Thank you so much.
Thank you.
Thank you.